Hello and welcome to your online lecture for the injury evaluation process. I'm Dr. Cosby and I will be leading a three-part series on this injury evaluation process. Part 1 will involve discussing the history, inspection, palpation, and special test process, or what we would call the HIPS process. Part 2 will be focused on movement-specific evaluative techniques, so range of motion, both actively, passively, and manually. And then part 3 will end the series just discussing some key anatomical terms that we all as healthcare practitioners should know. So today what we're going to discuss in this online lecture is the history, inspection, palpation process, which is an instrumental component to who we are as healthcare practitioners. We begin any patient evaluation with this HIPS process, so it becomes important to understand it, to understand the components, and to understand its importance. So our first stop is really in the area of musculoskeletal assessment. I think many of us wake up thinking about the musculoskeletal system. And so today we're talking about the musculoskeletal assessment because many of you are going into the field of sports medicine. That could include athletic training, that could include physical therapy, certainly could include physician's assistant, or maybe even you have aspirations of being a sports medicine physician. Regardless of the pathways to which you get to graduate school, one thing is consistent, and that is musculoskeletal assessment. And musculoskeletal assessment is just a small component within the actual pre-participation physical examination, but it is something that you as sports medicine or orthopedic healthcare professionals should be very good at by the time you leave this institution or our program. So if we're looking on the slide, what I have listed here are the key components to musculoskeletal assessment. They are the components that one should not forget when doing a full-on evaluation with a patient who walks into our clinic. What we know about musculoskeletal assessment, really patient evaluation in general, is that it always starts or begins with a really good patient history, right? And these are the questions that we're going to ask to help us determine how we proceed in our patient evaluation and with what techniques or special tests or range of motions we're actually going to be assessing or testing, right? That next step is then going to be the inspection or the observation of the patient. And this is key, right? In our HIPS, our history, inspection, palpation, special tests, we list history first. But when we really think about what really goes first in patient assessment, most often it's going to be that inspection or observation of that patient the minute they walk into our clinic, right? This will allow us to see how they move, specific gestures they might make, movements that they might avoid, right? And so that observation or inspection really truly begins the moment they walk into the clinic. Now, there is this inherent reality, right? That we as clinicians get busy and we're working with other patients, so we might not always tackle this phase of the patient assessment. But certainly once we start interacting with that patient, our observation shouldn't end until they walk out of our clinic. And then third and finally, we get into the examination of the patient, right? So we've asked our historical questions, we've observed their actions, and now we're in a place where we have some key information which would then allow us to kind of examine our patients, right? Examining our patient can include many things, but if you look at this entire list, what you will see is it requires the interaction of the patient and the clinician. So this is my favorite part of musculoskeletal assessment. It's going to involve movement testing, and by movement testing, range of motion testing, right? Or functional movement testing as well. It's going to involve special testing to help you get at your diagnosis or assessment of the patient's pathology and or injury. In some cases, we'll have to reflex test or test the patient's sensation. So can they feel things? Is there a neurological issue going on? Is the nervous system compromised, right? So that reflex or sensation assessment will allow us to tackle that component of the assessment. Then you have joint play, right? And joint play is the assessment of joint integrity or laxity of a joint, right? And so that will become important for ligamentous stress testing. And then last but not least is palpation, right? We're going to palpate that patient. We're going to touch that patient to figure out, number one, are there deformities? And then number two, are they tender to pain? Now, outside of the scope of athletic training, but certainly within the scope of other healthcare professionals, what we'll have to get good at doing is either referring our patients if it's outside of the scope of our practice, Maybe we have a patient who's extremely fatigued, for example, or exhibits systemic pain patterns across their entire body, and you want to get a blood workup to figure out what's causing these issues. You would refer out for lab tests. And then last but not least, we have to refer out for diagnostic imaging, right? If we suspect a fracture, if we suspect a rupture of a tendon, if we want to know the grade of a strain, right, or a ligamentous sprain, then we refer out for an MRI to determine what is the integrity of the structure that we're looking at. Now, what I will say is proceed with caution, right? Do everything you can in the examination of the patient to determine whether or not these are needed. All too often in clinical settings, especially in younger clinicians, they just refer out all the time. And what that does is it costs the patient time, and in some cases it will cost your patient money. So we want to be cognizant that we are strong musculoskeletal assessors, and so the only time you really want to refer out is if any of the following, right? We suspect a fracture, we suspect a rupture of something, we suspect maybe there's something going on systemically and we need to determine what that is. Then we want to refer out. So in terms of musculoskeletal assessment, essentially there are several different evaluative strategies that we'll discuss throughout the 3 different series that we'll discuss regarding patient assessment. But the first evaluative strategy is one that I don't think is new, and that most of us in this class or in this room probably already know, which is that we always perform each task on the uninjured limb first. In doing this really is a twofold strategy. Number one, it allows us to know what normal looks like, right? Even if that side had been injured previously, it still allows us to know what normal feels like on the uninjured side. So it gives us a baseline to compare to. The other component to examining the uninjured side first is that it actually allows us to develop confidence from our patient in us. In other words, if we go straight to the injured side and we touch them and we cause pain, they may not trust us anymore. So assessing or evaluating the uninjured limb is twofold. It gives us a side-by-side comparison. What's normal? What should we be looking for? And then it allows our patient to grow in confidence, right, as we begin our evaluation technique with our patient. Second, we should perform each task on the injured limb after performing the task on the uninjured limb. So this should not say first, it should say second, right? Want to perform each task on the uninjured limb first and then proceed to the injured limb. Now, in terms of evaluative strategies, this table here is taken from your textbook, but it is essentially has all of the segments or components of a patient evaluation. So it's history, it's inspection, it's palpation, and today we're going to be talking about special tests in this series. But we also need to consider a functional movement assessment, which will be part 2 of the series, joint stability test, which will be part 2 of the series, neurological screening and vascular screening, which will be in part 2 and part 3 of the series. Again, the focus of this series is to focus on history, inspection, palpation, and special tests. All right. So increase or decrease apprehension and muscle guarding. So this question right here to you guys is, do you think if you start on the injured side first and you cause pain, do you think it would increase or decrease apprehension in our patients and cause muscle guarding? Right, you guys got it. Essentially, if we start with the injured limb first, it's going to cause an increase in apprehension, and more than likely they're going to guard, which means you may not get a good laxity assessment, or you may not be able to get a true feel when it comes to your special testing technique. So please ensure that you test the uninjured side first in all that you do. In terms of clinical assessment versus acute evaluations, you guys have to remember that these are 2 different types of assessment techniques, right? A clinical assessment is something that can be long, that can take an extended period of time because that patient has more time and is sitting in the clinical setting, so you can go through all of your history, observation, palpation, and special test. But then you're going to have cases where you have to do an acute evaluation, right? Which means they are in a game, they come to the sidelines, they're injured. So your evaluation or your patient assessment is going to look a lot different, right? You're going to shorten what you would do in a clinical assessment. And these become important as you go through internships or practicum, or as you start to work with patients in the clinical setting, to keep this in mind, right? Yes, you all are students, But if a patient comes into the clinic and has the time, you take all of the time you need, sit down with that patient and get a thorough assessment. If a patient is in the middle of a game and needs to get back in, you don't have the time to do a full assessment. So figuring out what things are key in that history, inspection, palpation, special test, and how quickly can we do that to help determine if that patient can go back to play. So what I would say is this is a lengthened assessment. This is a very short and expedited assessment. And if you get good at these acute evaluations, your coaches are going to love you, because then they don't have to stress about what their athletic trainer is doing, what their physician is doing, what their physical therapist is doing, what their physician's assistant is doing. They're really focused on their competition and not having to worry about whether or not they have to keep checking on you. So in terms of special considerations, there are some key things that we as healthcare practitioners need to consider when we work with patients. Number one, discretion. Discretion is going to be everything. So discretion of your patient's information, but then also if you're working with an injury that requires you to be discreet in the way that you're palpating or move to another room to have patient privacy, right? Those are ways in which discretion becomes extremely important. Remember, with minors, we can discuss injuries with the parents, but as they become adults, then we no longer have to discuss injuries with the parents. But you'll find in college, parents will call you and ask you, and unfortunately, you cannot answer if that patient is 18 years or older unless they've signed a waiver. The same thing applies with media. Some of you are going to be working D1, maybe even professional setting. So the same thing applies both ways. You need consent from adult patients to discuss their medical conditions. One of the other issues that we have to consider is religious considerations. So some of the student athletes that we work with, depending on what they believe and what they practice, an example would be they may not be able to work with opposite sex healthcare practitioners, right? And so you'll have to take that in consideration. They may not be able to receive treatment for acute injuries or a blood transfusion. So knowing your patient's religious preference becomes important and is key in patient assessment. It's why we ask on our pre-participation physical examination about their religious affiliation. So it becomes important when we need to treat. And then informed consent, we should talk about that a little bit, but informed consent means either you assume that the patient would want you to treat them. So if they're unconscious, right? Unconscious, you assume that they would want you to treat. And there's also the written waiver that I alluded to, right, where they could sign a waiver which says you can talk to whoever about whatever. Here on our campus, the waiver looks something like this. You can talk to the following individuals about my medical condition, and we have listed on-campus media, parents, coaching staff, assistant coaches, friends, athletes, right, other athletic trainers, and they can check or uncheck any of the above individuals, right? And so as you begin to prepare to have your own clinic or work in your own clinic, one of those things that you need to think about is what does that checklist look like for you? So the next thing that we have to consider in our historical question is the onset. How did the injury actually happen? Was it sudden? So was it like this macro trauma, acute trauma? Was it insidious, meaning chronic? It happened over time. Or is it more sporadic? In other words, does it come and it go? It's not always there, but when you exercise or you get out of a chair or you do something weird, it comes back. That's a historical question that becomes important because it allows us to know the nature of the injury. Is this an acute traumatic injury that we have to evaluate, assess, and refer right away? Or is this a chronic, insidious, micro-traumatic injury and we're concerned maybe they have a stress fracture, so we have to reduce their load? Is it something that comes and goes? In competition, this is important because, okay, if it only happens in the morning, then we adjust our practice and we practice in the afternoon. If it only happens with jumping, then we alter the patient's practice and coach, they can't do jumping. So these are all important questions that we kind of have to ask our patients to help us be better clinicians for them. Okay, so you're looking at this stress strain curve, right? So we have a stress here on this axis, we have strain here on that axis. And so what we're looking at is as the stress and the strain increases, the different types of injury will happen, right? If stress is high and strain is high, then more than likely we're going to have an acute traumatic injury associated with that pathology, right? If stress is relatively constant, right, and strain is relatively constant, then what we'll see are those insidious kind of strains, or those micro-traumatic kind of strains that happen over time. And so this becomes important to consider with any injury. How much stress was applied and how much strain was applied. Because if it's a lot of stress or increased stress and increased strain, then essentially we're expecting something traumatic or macro-traumatic to happen, right? If it's just a constant stress and strain, over time, what we're expecting to happen is we're expecting to see some type of overuse injury. So again, a very important historical question to ask. Okay, so as we begin to navigate into the history section of this online lecture, let's talk about what history is. History is important because it's going to help you identify the mechanism of the injury, right? That's a question that you're going to ask that patient. It's also a good connection piece for you to figure out what the previous history is for that particular patient, right? So, and this becomes important, like past history. Do you have to go back to when that patient was a child? No, but a question such as, within the last 2 years, have you ever hurt your ankle? In the last 2 years, have you hurt your knee? In the last 6 months, right? That's still considered past history. We can also ask about any underlying pathologies, anything that's been bothering them that they've been ignoring. That happens a lot. Many of you are probably student athletes or have been around athletes. So you know there are some athletes who go, oh yeah, I tweaked my neck, it's no big deal. And then 2 weeks later they come in and they have massive neck pain. And so that's an underlying pathology that was there, but that we ignored, and now is an acute pathology that now we have to treat. And then this one I'm kind of going to overemphasize because I don't think it's emphasized enough in clinical practice. But what impact does that injury have on the patient's life, right? We know that student athletes in particular are drawn to sports for a reason. Number one, they're competitive, but number two, there's a social component that exists within each of our student athletes. And so removal from a sport might cause depression, right? You might see a decline in patient grades. You might see the patient withdrawing from the team. And so these all become important questions. Yes, mechanism of injury is important. Yes, past history is important. But certainly asking about how the injury is impacting life. Are they going to lose their scholarship and they're stressed as a result? Becomes an important clinical question to ask. All right, many of you are good communicators. I know this about you, but there are some who may not be communicatively, clinically mature yet. When we are working in the history section, one of the things that we don't want to ask are yes or no questions, right? Does it hurt? Yeah. Versus, what type of pain are you having? That's an open-ended question, right? So we want to avoid asking the yes-no questions because they don't allow us to truly get the big picture of the injury. We want to ask open-ended questions. And yes, there are times where yes-no questions are appropriate. For example, do you have pain? Yes. But then that yes should take you to an open-ended question like, describe your pain to me. Does that make sense? So yes-no questions are good, but then follow up on those yes-no questions with open-ended questions where you can. All right, so let's talk about past medical history and previous medical history because they're a tiny bit different. So if we're thinking past medical history, essentially what we're thinking about is non-acute examinations. So they've had physical exams. And so in the past medical history, when was your last physical exam? What previous health conditions have you had? Not just injury, but health conditions. Are they a diabetic? Do they have a history of COPD? Do they have a history of hypertension in the family, right? And then we're also trying to look for predisposing factors, right? So let's think a student athlete is 6'6", has an amazing wingspan. So we're thinking, okay, probably a candidate for Marfan syndrome, right? What predisposing factors do they have? They lack flexibility in their hip flexor. So maybe they're going to suffer from a hamstring strain if they're a track athlete, right? These are all different questions that we get at to try to figure out how we can prevent things from happening. So that past medical history, really what we should be thinking of it as is like a pre-participation physical examination where we're getting everything about our patients, right? On the other side of this is previous history. which is a little bit different. So this is all about the injury, right? So we've got medical history, and then we just have previous history questions, which is more injury related, more specific. So if you're going into the field of sports medicine, athletic training, then these questions are the questions that we're going to focus on and that we are going to ask, right? Injury. Have you had an injury to this side or the other side, right? Have you had an injury to this joint or the other joint? Have you had an injury to this limb or the other limb, right? Describe and compare what the current injury feels like. Compare it to the previous injury. Is it worse? Is it better? Is it the same? You don't know, right? And then do the current symptoms that they're presenting to you, do they duplicate the old injury, right? So we can see how obtaining a medical history is a lot more time consuming and a lot more invasive, but certainly needed. And we can see where taking a previous history becomes important as well, because the previous history is what we're going to do 90% of the time, right? We're going to get this in our pre-participation physical examinations, but we're going to do this all the time in our patient assessment. We want to know side-by-side comparisons. We want to know history of previous injuries. We want to know what it felt like if they were injured before and what it feels like now. These are all important components for us to consider in a history assessment. And then, are there any possible sources of weakness from a previous injury? So if they were previously injured, did that injury not heal, and as a result it led to a different injury, right? We can think about hamstring strains, for example. If they had a hamstring strain, did that lead to a glute strain? Did that lead to low back pain? So we can see how one injury could certainly lead to other injuries up or down the kinetic chain. So it becomes important to not just consider the joint or the injury you're evaluating, but also the bigger scope of the kinetic chain. Okay, so past medical health. So we're going to go with general medical health. So that could be any comorbidities, what their current health status is, any blood tests that they've had, right? Any lab work that they've had, any medications that they're currently taking, and do they smoke, right? And a lot of times students are like, why do we care about this? Well, we care for many reasons. What we know about smoking is it decreases exercise tolerance. So their ability to exercise for a longer or extended period of time is reduced. Obviously, it increases the risk for cardiovascular disease. But one of the things that I'm learning over time is that smokers, if they smoke and they have fractures, apparently it takes longer for the osteoblast to build bone. So they actually have a longer healing period. And so these questions, you can see, albeit are important, but certainly aren't something we're asking when an athlete comes in is injured. These are questions we're asking the first day that the team gets back to campus in our physical examinations. All right. Other questions to consider in the past medical history is, have they had any diagnostic imaging, and if so, what for? So by diagnostic, I mean CAT scan, MRI, X-ray, ultrasound. What for? We already talked about, is the patient on any medication? This becomes important because we want to know if it's going to interact with other medications that they might receive along the way. And then does the patient suffer from any abnormal physiological functions? And the one that I think of the most is the bowel bladder problems, because that can then be linked to issues in the spinal cord, but certainly could be congenital as well. Does the patient have any other problems or complaints? So you can see in this physical exam, we're taking a crazy thorough history, and it's necessary, certainly, but not all the time. Okay, guys, remember we talked about the clinical assessment. Maybe we do that there. We talked about the acute assessment. We certainly wouldn't be asking all of these questions here, right? We would only be asking injuries that pertain to the questions that pertain to the actual injury. Okay, so the next question, and now we're kind of getting into that medical history, is mechanism of injury. So how did the injury occur? Was it macro trauma? Was it micro trauma? Was it sporadic, right? Remember that? We want them to identify or tell us what structures are involved. And one of the key questions that I always ask is, was there a sound or a sensation that you felt? A burning, a stinging, a snap, a pop, a crack, right? These become important because they allow us to know, was it ligament? Was it tendon? Was it muscle? Is it nerve? Right? And then onset and duration of the symptoms. So was it an acute, like it happened right away, or it took a couple days to actually start presenting itself? These all become important questions that we want to ask our patient who's sitting in front of us. Okay, in terms of other historical questions, we need to ask the pain question. So you'll take another class with me at some point in time, but I say pain is a multi-entangled beast. What do I mean by that? That a patient who experiences pain sometimes doesn't just experience pain in the area of the injury, but might also have other painful episodes across their entire body because the nervous system is connected and entangled, right? And so when we think about pain, the historical questions that we should be asking is the location of pain, the type of pain. So is it sharp? Is it dull? Is it achy? Does it burn, right? We should be asking if it's referred pain. So example, I took a blow to my spleen, but yet I have pain in my upper left-hand shoulder, right? That would be an example of referred pain. Is it radicular pain? So does it radiate, right? It doesn't just stay right local, it actually radiates, right? And then we're thinking nerve probably involved some way, some shape, some form. What does it present like on a daily basis? I usually ask the history question. If they've been in pain for 5 days, describe 2 days of pain. Is it similar? Is it different? Is it inconsistent? And then last but not least, definitely important is what exacerbates or causes the pain? And then what can you do to relieve it? And in patients where you can't relieve it, you're concerned, right? Because then you're thinking, okay, it has to be stress fracture, it has to be cancer, that's probably extreme, but it has to be something, a pain generator that is significant enough to not allow the patient to relieve it, right? Whether that's with oral NSAIDs or painkillers, whether that's with sitting in a specific position. So these all become important pain questions to ask. So if you haven't been asking them, certainly a quick 5-second ask doesn't hurt anyone. Okay, so now what we're talking about are there other symptoms, right? Because we can certainly miss a question, right? Because we think we're being so specific. I turn to my patient and just say, is there anything that I didn't ask you about your pain that you want to tell me, right? And then you never know, they can come up with the craziest things. And then the other thing that we want to know, the other item that we want to know is, have they had any treatment? So what have they done to treat? Have they iced? Have they rested? Have they compressed? Did they take a lot of pain meds? Did they massage? What did they do and how effective was that? And then effective traits. So what things were effective in the treatment? And then last but not least, do they have disability or limitation? So what can't they do? What is this injury causing them to not be able to do that they normally would do? Walk upstairs, get out of their bed, drive a car, pick up their backpack. What are their disability or limitations as a result of the injury? So we're continuing on pain, and if you can't tell, pain is an important component to the history evaluation process. There's intensity, right? So on a scale of 0 to 10, tell me what your pain feels like, right? So on a scale of 0 to 10, tell me what your pain feels like. Or it doesn't hurt at all, or it hurts a whole bunch, right? Remind me in class to tell you what I ask. Won't say it in the video. And then, so the duration, does it last for an hour? Is it just a quick burst and then it resolves itself? Frequency, how often does the pain actually happen? We've already talked about location. We've already talked about type. And then what is it associated with? Oh man, when I flex my hip, it hurts. When I extend my shoulder, it hurts. So is the pain associated with movement? Is it associated with laying or positions? What is it associated with, right? So I'm hoping you guys are getting a grasp on the history section, right? You've got the historical questions. You've got the past medical history, which is robust, right? You've got previous history, which is all about the injury. And now you've got these pain questions that you have to ask, which will help you determine what structure is injured: nerve, muscle, tendon, bone, right? These are all important questions. So let's look here at this pain and function scale. I really love it a whole bunch. When I found it, I got excited. And so pain and function have levels, right? And so level 1 is going to be, they have pain just after the specific activity. And this is a good type of pain to have if you're an athletic trainer or you're an athlete or a coach, because they can get through everything. It's just after they're going to come into the clinic and they're going to need help, right? Then you have level 2. It starts with the activity, but then once they're warmed up, it goes away. And so again, I don't know if this is a good pain to have, because I mean, if I can't even, like, depending on my pain tolerance, if I have pain in my first 2 steps of activity, I'm probably going to come see you and say, oh, I can't practice today, right? So you have to have a patient who wants to work hard, who wants to push through with this level 2 pain. With a level 3, they have pain during and after the activity. But the cool thing is that it doesn't affect performance. So can this athlete participate? Most certainly, right? Because it's not affecting performance. So I would say like a level 1 through 3, they can still participate. Your treatment paradigm should be adjusted, right? You know, for this particular patient, afterwards you need to be prepared to reduce their pain. You know, for this particular patient, you're going to have to warm them up really well before they even start their actual warm up, right? You know, for this particular patient, okay, maybe we're taking some NSAIDs to get you through, right? Because it's not impacting performance, and we're pre-treating before and after, warming up before and then treating after. It's our level 4 through 7 patients that really cause us the most problems, because most often we have to remove them from participation. So it's pain during and after activity that does affect performance. So anytime pain affects performance, we have to reduce their ability to participate in competition or practice. It really just depends. Certainly doesn't have to mean they can't practice, but if there's something that's exacerbating the signs and symptoms, then we remove them from that particular activity. Level 5 is a patient who has pain with activities of daily living. So that's walking, that's sitting, that could be driving a car. It just depends on what their activities of daily living. So it's not even like activity is exacerbating it. The low level activities are exacerbating it, right? Then you have your level 6 and your level 7. So level 6 is that constant dulling at rest, but it does not disturb sleep. So we're not concerned about a stress fracture yet, right? Because if we have a stress fracture, we know that that pain is going to disturb sleep. It's going to wake them up at night, but they certainly probably are getting there. And then we have level 7, which is where they have pain constantly, and that pain is waking them up at night. And so this is when we're referring out, right? We're referring out for an x-ray or a bone scan to ensure that they don't have a stress fracture. So I like this pain and function scale because it allows me to kind of see, where does my patient live in terms of their pain and their function, right? And if they're level 1 through 3, I'm comfortable with them competing in sport. As they progress to that level 4 through 7, particularly 6 and 7, that I'm getting concerned that that patient is at risk for some type of bony reaction, right? And so we pull them from the sport to ensure that they don't get injured. Okay, so pain can last, can have a duration, right? And that duration is important because it kind of drives how we treat our patients. So, for example, if acute pain usually lasts 7 to 10 days, and then after that, we should hope, like after an acute injury, that at day 10 the pain should go away, or it should be resolving itself. It's when we get that subacute or chronic pain. So subacute pain stays for 10 days or could go all the way up to 7 weeks, right? So 2 months, give or take. And then chronic pain just lasts forever. It doesn't go away. And that chronic pain doesn't have to be like constant, right? It could be sporadic. So it just comes on and off. It's every so often, right? And so knowing these will tell you how the injury is resolving itself. If it goes away after 7 to 10 days, then you know that that patient is getting better and they're progressing. It's when we're in that 10 plus period that we're concerned, right? Because we know injury healing, we know that that patient's pain should be resolving itself. And if it's not, then are there other underlying factors that we missed in our initial assessment? So this is when the subacute or the chronic type of pain, we have to go back and we have to redo our evaluation to see if we missed anything along the way. All right, so let's look at pain from different levels. So we have acute phase pain, which is going to last 7 to 10 days, right? We said that. We have subacute pain, which is going to last 7 to 10 days, or 10 days to 7 weeks. And then we have that chronic pain, which is anything after basically 2 months. So in the acute phase pain, we basically can say a few things have happened. We evaluated the patient in a timely fashion, or the patient came into us at a timely fashion. We can say that we treated that patient, we cared for that patient's healing, right? Does that make sense? Yes? And so we release them. But if that isn't the case, so that patient isn't healing as anticipated and that pain progresses and they still have it for 10 days or more, then we have to intervene, right? So we have to say, okay, what we did in the acute phase didn't work. So we have to reevaluate and figure out if the treatment paradigm is truly good for the patient that is sitting in front of us. And so then in this case, we have to consider other things. So number one, are there psychological factors that are involved in the injury? So maybe the patient is expecting there to be pain, so there's pain, right? And so then we have to consider, do we remove the patient from participation just to allow the injury to heal itself, and then also mental health wise to get the patient back to a place to where they're confident about their pre-injured status. Yeah. However, sometimes psychological factors take over. Sometimes pain does not go away and it lasts longer than 7 weeks, and so then that patient is now lumped into the chronic pain category. So that pain is there beyond what's anticipated for the type of injury that patient has, and so we remove them from activity. And really truly what we look at is, okay, what things are causing the pain? What is it? What are the pain generators? Is it the thought of returning to activity? Is it movement based? Is it static based? What is it? And then from there we have to figure out, okay, treat conservatively, and maybe even refer out, right, to ensure that we didn't miss anything along the way. So these are the 3 phases of pain. Again, acute phase, you're looking at 7 to 10 days, subacute 10 days to 7 weeks, and then chronic, you got that, outside of 7-week range. So I'd say about 2 months. And this kind of just tells you what you should be doing in each of these phases of pain with the patient. And the big deal is, some of us aren't going into any of these professions to be counselors, right? I think that's probably not what we signed up for, but it certainly is innate in most healthcare professions. And so it becomes important that we're considering these psychological factors. And if we go back a few slides where I said, how is it impacting their life, right? How is it impacting what they can do? It becomes an important clinical question, more specifically when that pain lingers for more than 10 days. All right, now we're moving to the I, which is inspection. And so I'm going to say some things, and most of you always chuckle. But the biggest thing is, in order to evaluate an anatomical structure, the patient has to be dressed appropriately, right? What do I mean by that? If we are assessing a shoulder, that patient should be wearing a tank top, right? Or an egg tank if you're a guy and you're uncomfortable taking off your shirt completely, because we want access to the glenohumeral joint, right, you guys? If my patient is getting an ankle assessed, then I want to make sure they're comfortable taking off their shoes and their socks. You will find that some people, especially those that have foot ailments or abnormalities, are very apprehensive to take off their socks. And so I want to make sure the patient is dressed adequately to allow you to do or perform an effective patient assessment. You're always going to tell that patient what you're doing and why, and we'll talk about this more in the palpation section. Remember, what's normal for one person isn't normal for the other. So normal is going to cover a wide range. I'm saying when you have a patient sitting in front of you, he or she is a blank slate. Don't make any assumptions about how they should present, because 2 ACL patients could present completely different. One ACL rupture could have no joint swelling. The other ACL rupture could be obvious with lots of joint swelling. So don't make an assumption, because normal is not normal to the next person sitting next to you. And then is what you are seeing what you are seeing. Ha! I love this one. So what do I mean by that? It means if you see swelling and it's there and they have pain, could it be a knee injury? The answer is yes. But there are times where a patient just has swollen knees and nothing's wrong. So you want to you inspect, and then you use your inspection to drive your palpation, and you use your special task to drive your assessment. Don't make an assumption in the inspection phase of the evaluation. All right, so in terms of inspection, we start with the immediate observations. And so by immediate observations, I've already alluded to this, right when the patient walks into our clinic, we want to assess them. We want to look at their gait. We want to look how they're posturing. We want to look at how functional they are when they think we're not watching, right? It's the best way. It's a true gauge of figuring out what's going on with our patients, right, you guys? So think about this. The patient who comes into our clinic and has a shoulder injury, if they're high-fiving everyone, well, I already know they have range of motion. But if that patient is holding their shoulder like this when they walk into the clinic and they don't think anyone's watching, then I certainly think something's going on, right? So we want to observe them when they come in, and your inspection begins the moment they come into your actual clinic. Next, what we want to look for in the inspection is deformity, right? So that deformity could be very subtle. You could barely see it, or it could be very gross. meaning it's large, it's there, it's obvious, right? And so you're looking for any type of deformity, most often with a dislocation or a fractured bone. You'll see some type of deformity where they're subtle or gross. You look for swelling, right? And a hemarthrosis. So what do I mean by that? That is joint bleeding. So you'll see like bruising around the joint. You're going to look for edema, which is a form of swelling. And so it becomes important that you take girth measurements. And we'll talk about that in lab. We'll actually do the girth measurements in lab. But what do I mean by that? You're going to measure each limb to see how much swelling is present. You're going to look at the skin to see if there's redness, if there's ecchymosis or bruising. And then you're going to palpate the skin for signs of infection. So are they warm to touch? Are they red? Is there pus, green, yellow coming out of the wound? We're looking for signs of infection. So you can see inspection is pretty intense, but relatively you can do inspection in all of 15 to 20 seconds because you're just looking at the injured joint. Okay, so when we inspect, we are also looking for any overt pain behavior. So remember I said the patient comes into the clinic doing this, right? They're guarding or they're bracing themselves, right? We're going to look for a patient who's kind of doing this while they're waiting for us to kind of reduce their pain. So they're rubbing, or they get on the table and they, right? That's a grimace, or they're sighing at the thought of what you're getting ready to do for them. These are all inspection. They require you to look at your patient as you're assessing them, right? I know a lot of us, at least when we're new in the clinical setting, we just have our head down and we're writing all that they're telling us, and we're missing the inspection piece. We're missing seeing what they're telling us without telling us. So make sure you're observing or inspecting your patients. So red flags in the history and inspection component: severe unremitting pain. So it does not go away no matter what they do. Pain unaffected by position or medication. So that kind of ties into that unremitting pain. But the reality is you can't put the patient in position to reduce the pain, and you can't give them any type of medication that reduces their pain. Severe night pain because we're worried about a stress fracture or a fracture. Severe pain with no history of injury. They just come in and they're complaining of pain. Usually that's systemic, like a fibromyalgia. Severe spasm. And then last but not least, psychological overlay. So again, we're going back to this whole, like, we're counselors somewhat, right? This idea that we need to make sure that not only are we assessing our patient's injury, but we're also assessing their mental health in some way, shape, or form. All right, so inspection will also involve a functional analysis. So we're going to have patients perform these functional tasks, probably more sport specific, and that allows us to identify, like, are there impairments in their movement? Are there impairments in their ability to perform a specific skill or task? That's a part of the inspection, right? It doesn't seem like it because they're doing the task, but you're watching it, hopefully, right? You're not going to just send your athlete to the field and say, go do this task and come back and tell me how it is. I hope that you say, let's go to the field, let's do these tasks, and let me see what your movement looks like while you're performing those tasks. All right, so physical examination, the goal of the physical examination is to rule out injury. Like, if nothing else, with musculoskeletal assessment, we want to rule out all of the catastrophic injuries that it possibly could be. This will then allow us to kind of whittle it down and come to a clinical diagnosis, right? So through this process of history taking and inspection, we're going to identify the impairments in that patient, and we're going to figure out what their functional limitations are. And this will hopefully allow us to get a really good assessment or diagnosis of what the injury is. So palpation wise, let's talk about it. Palpation is the art of touching our patient. And this is my favorite part, not the touch part, but what the touch can tell me, right? The touch, your ability to touch your patient, allows you to feel their anatomical structure. So there's this innate relationship that exists between your hands and the anatomy of your patient. And so most often this is performed bilaterally, on the uninjured side first and then the injured side. And most often there's two sequencing strategies that one can take. The first sequencing strategy is that you could choose to palpate all the bones, all the ligaments, all the muscles and tendons in that order, right? So if I'm doing the ankle, I'm going to palpate all of the ankle bones first, and then I'm going to palpate all of the ligaments of the ankle, and then I'm going to palpate all of the muscles and tendons of the ankle. The second strategy is you palpate all structures in any particular order, but instead your ordering is I'm going to either start proximal or distal, right? I'm going to start away from the injury or towards the injury. And I have an inherent bias to use sequencing strategy number 1, because what I find when I'm working with patients is I don't forget something. I don't forget to palpate, right? I got all of my bones, check. Next, moving to the ligaments. I palpated all of my ligaments, check. Next, moving to the muscles and tendons. Now, you certainly could start in a different order. If you don't want to start with bone, for example, you want to start with ligaments, you certainly could. But I like sequencing strategy number 1. I'm not going to tell you what to do or how to do it. I can only present the 2 most common ways to palpate a patient, and then you can decide what that is for you. So in terms of palpation, really what we're looking at here is, are they tender to palpation or to touch? Do they have trigger points? Is there a change in tissue density? So you're sweeping along the patient and, oh, right here I feel tightness, and then, okay, not anymore. Or you're sweeping along the patient and you feel a divot, right? And so there's swelling in there maybe, so the tissue's softer than it normally would be. Is there crepitus? Now, crepitus is hard to describe, but essentially crepitus is like, you know that sound you make when you put your fingers on a chalkboard? That's crepitus, right? And crepitus is a sign and symptom of swelling, number 1. Certainly could be a sign and symptom of an inflammatory response in the Achilles tendon. And then you want to check for tissue temperature to rule out infection. That ends our slideshow for the history, inspection, palpation component of this lecture. I really need you guys to own these 3 components of the HIPS process. They're hugely important. In the lab, we will spend tons of time on the special test, but really truly watching this and maybe even re-watching it to understand just how important inspection, palpation, and history are becomes a part of your